ECMO. Now, the role of steroids. In patients who have persistent requirement of vasopressors, there is an indication for addition of corticosteroids, which should be given in the dose of 200 mg per day, either as 50 mg IV 6 hourly or as a continuous infusion. Why a continuous infusion? Because it leads to better plasma levels. Also, it helps in a continuous monitoring of blood sugars. Should be given in patients who have norepinephrine or epinephrine dosage of more than 0.25 mics per kg per minute for at least 4 hours after initiation. So, based on the pooling analysis of 16 studies, were corticosteroids beneficial? So, they saw that mortality was reduced as well as mortality also. Length of stay, everything was improving, but there was also patients who had hyperglycemia and hypernatremia, which was not very significant. So these are the various extracorporeal therapies which are being used in sepsis with septic shock, like cytosorb, Torre, Oxares, CPFA. So I think today we'll just concentrate on sepsis with septic shock. So these perfusion filters will study some day again. Now, RBC transfusion targets, very important. For adults in septic shock or sepsis, a restrictive transfusion strategy is advisable. Restrictive means a hemoglobin of around 7. But it should not be guided only by HB levels alone. It should be dependent on patient's overall clinical status and his other parameters, like if the patient has suffered from acute MI, or if he has severe hypoxemia or acute hemorrhage. So you might want to go above on those levels. Immunoglobulins, no role. Stress ulcer prophylaxis, yes, very important. In patients who have at risk for GI bleed, stress ulcer prophylaxis is definitely recommended. Thromboembolism prophylaxis, recommended, could be in the form of pharmacological prophylaxis, or could be in the use of, you can use stockings or pumps, or you can use low molecular weight heparin. Low molecular weight heparins are preferred over unfractionated heparin. Renal replacement therapy, yes. So in patients who have AKI with sepsis or shock, who require renal replacement therapy, continuous or intermittent renal replacement therapy, depending upon which modality is available with you and how important it is for you to remove the toxins, or for what purpose you are using it. So that should be used in patients who are not having definite indication for renal replacement therapy. Even continuous or dialysis should not be done. Glucose control, very important. Glucose levels should be titrated. The target blood sugar levels should be between 140 to 180 milligram per deciliter. Above that, you should start them on insulin. Vitamin C has no role. Oranges and ACTS trials, they show that there is no mortality benefit with any vitamin C, thiamine, and hydrocortisone in patients with septic shock. Bicarbonate therapy as such is not recommended, but there are subset of patients in septic shock, like with patients who have severe metabolic acidosis or acute kidney injury. The balance effects probably favors the bicarb usage, which is weekly recommendation for the use of this bicarb in this subset of patients. Nutrition. Enteral nutrition should be started as soon as possible. Suggestion from there, from the septic guidelines, is within 72 hours. So this is just the palliative care, how you counsel the patient, how you should make approaches, how you should make all these units in your hospital or in your ICU so that patients can benefit from that. Post-discharge follow-up should be done within, it should be started as soon as the patient starts getting better, so that you have to take care of his physical and along with that his mental health also. Uh, thank you. So that's all. So